going to move on to Zoe Kourtzi, who is Professor of Experimental Psychology and Computational Cognitive Neuroscience at the University of Cambridge, to talk to us about AI for better brain and mental health, from cloud to clinic.
Thank you. Thank you very much for the invitation. It's really wonderful to be here. And thank you, Andrea, for a great introduction. No pigeons, sorry. Just really to state the problem, as you've heard in previous talks, looking into brain diseases, it's really critical in terms of societal benefits. We know that 1/3 of the global disease burden comes from neurological and psychiatric disorders. We have experiencing a serious mental health crisis, especially in young people, and dementia is hugely costly, huge societal burden, and the primary cause of death in the UK. AI and machine learning provides us really with tools to be able to make interpretable predictions for brain diseases. And I wanted to tell you a little bit about this kind of success story in the space of dementia, linking also to Andre's talk. So what are the challenges we have? First of all, one key challenge with dementia, except of course of the very high costs and the fact that currently 55 million people worldwide live with dementia, is the fact that dementia is actually very heterogeneous. So we don't have one type of dementia, we have many different types of dementia, and we also have people that present with comorbidities that show very similar symptoms to dementia but don't have dementia pathology. So when we try to diagnose dementia from the first symptoms, we actually know that we have up to 30% misdiagnosis. Now, this is really huge for healthcare systems. It's huge for patients. Patients typically at the initial stage, when they experience symptoms and they'll go to their GP, they will have some basic kind of cognitive test and maybe an MRI. And if there are very early stages, most of the times the diagnosis is not conclusive. And then they will be sent forward for more invasive tests, for example, a lumbar puncture or a PET scan, which are highly costly, highly actually invasive and burdensome for the patients. And the patients effectively go on a trajectory which is quite anxious. Now, if this patient does not have dementia pathology, but they have, for example, cardiovascular disease, diabetes, or they have depression and anxiety, they might be experiencing similar cognitive symptoms like memory loss or confusion, but they don't have dementia. Now, their symptoms are only going to get worse if they are going down a very lengthy, burdensome, anxious pathway for them. And of course, the NHS is investing a lot of resources to people that might not actually have the disease. Now, to make this even a harder challenge, so far, for about 30 years, clinical trials targeting dementia pathology had been unsuccessful, one after the other. Only the last 18 months, actually, we have seen 2 monoclonal antibody drugs that have been successful, and they show changes in cognitive symptoms, up to about 27%. Now, these drugs, one of them has actually just been approved by MHRA, not nice yet. They're hugely expensive. In the US, they cost $8,000 a month, and they have severe side effects. They can cause death due to severe neuroinflammation. So who do we give these drugs? When do we give these drugs? There are 127 targets currently ready to be tested. How can we make our trials more efficient, cheaper, faster, and with better outcomes? So this is really the space where we strongly believe that machine learning can come in and help us to address all of these challenges. And today, that's what I want to show you, how we can build models that they are transparent, they are interpretable, they are robust, and they can be translated to clinical practice. So you've seen this picture, Andre had it. It's kind of like the holy grail of dementia research. What I want to emphasize here is that the earlier we are trying to predict dementia pathology, the least predictive ability we have, because the tools we have are not sensitive. If we want to make a difference in patient well-being, in drug development, we need to predict early. If we predict late, we have huge neurodegeneration in the brain, and therefore we have in our hands a very different problem. We have a brain repair problem, which is a very different ballgame. If we want to make an intervention that is successful, we need to be early. We also know that changes in the brain that might cause dementia start about 10 to 15 years before we have symptoms. Now, this is a golden window of opportunity to intervene. If we intervene early, we can change 40% of dementias just simply by lifestyle interventions. We can change the pathway of the disease. We can have better treatments for patients. So it's really important to intervene early. But the problem we have, early we don't have good markers. PET scans are unlikely to show anything. MRI scans with a naked eye, again, unlikely to see anything. Blood markers that are now coming into play potentially can help us here. And here's exactly the problem. So as I said, currently an individual that experiences symptoms will go to their GP, they'll have a basic kind of cognitive scale run into them. If the scores are looking low and there is reason for concern, they get referred to a memory clinic and they will have an MRI scan. Now, if looking at this MRI scan, you can see that there is atrophy in the brain, there is lots of CSF, large ventricles, therefore there is reason for concern. This actually is a brain of an Alzheimer's patient. But if I show you these two brain scans, it's really difficult to tell which scan is from a healthy brain versus a brain at early stages of disease, what we call mild cognitive impairment, or MCI. And actually, if I didn't have my notes, I wouldn't know. Either the one on the right is the patient that is at early stages of dementia. So this is a very difficult problem for clinicians, and that's why we bring in machine learning models that we built to be multimodal. At that very early stage, no marking can give us a reliable, robust, conclusive prediction. Therefore, we train the models with thousands of data from research cohorts, including many different modalities. So we include genetics, we include MRI, we include biomarkers from PET scans, amyloid and tau, accumulation, we include cognition, and now we've got blood markers that we can also include in the models. And we built architectures that we ensure they are transparent and clinically relevant. So the very first step of the architecture we make is we test the markers that we put into the model to make sure that they are clinically relevant. I'll show you how we do that. Then we go through a basic classification problem that is actually quite subtle and quite precise. We ask the question not whether the models can separate healthy from dementia, but actually whether the models can separate individuals that will remain stable in their brain health trajectory or they will progress, they will move away from healthy aging. And finally, we turn to these models into trajectory predictions. We are interested about stratifying the patients based on their prognosis rather than based on what happens now. And the reason for that is because we are dealing with neurodegenerative disorders, which means we are interested to understand how people progress, how quickly they will progress, or maybe whether they will remain stable. So this is the type of architectures we built, and I'll show you a little bit about the model. So starting with predictors, as I said, we make sure that they are clinically relevant. So for example, as I said, we give the models many different data. An example is MRI scans. The first thing that we do is we look what features actually we can extract from the models. Here is a simple example where we start with structural MRI. We do a PLS regression on the MRI images against changes in cognition. Effectively, we ask the question of what are the features in the brain that predict cognitive decline. And it's no surprise, actually, that the features we find are around the entorhinal cortex. Now, when I showed this to clinicians, they kind of went, well, but yeah, what did you expect? But for us, this is the first breakthrough, because this means that our models then can rely on clinically relevant features. And it's interesting that the features we find are not in hippocampus. They are in entorhinal cortex. We know from research that in entorhinal cortex, we see the very first changes because of dementia pathology. So when we look at that very early stage of we try to predict dementia pathology at early stages of disease, these features are highly clinically relevant. Then we move into looking at this kind of hidden space of the models, and we ask the models to separate the patients that they will remain stable in their trajectory compared to patients that they will progress. And this is a very fine kind of discrimination Depending on the data that we will put in there, our models can get up to 92% with sensitivity and specificity. And effectively, what we built is through metric learning, we work in a space where we look at prototypes. We have two classes to start with, stable versus progressive, and we look at these two prototypes, and we calculate then the distance between these prototypes based on a scalar projection method. So what we ask is effectively, if one prototype is the stable prototype, any new patient that comes in, it gets compared to that prototype, and we ask, will they remain stable, or will they start moving away from that stable prototype towards disease? And effectively, what we can extract through this is a score from this modeling architecture that tells us where a new patient stands compared to healthy, stable cognition, and how fast they move away towards disease. So the higher the score, the further, faster the patient is moving towards progression. Now, how do we validate these models? We have individual scores per participant. We cross-validate this within cohorts, research cohort data, ADNI, Andrew mentioned it, but we also looked here at many different data sets. Dementia is a global problem. We cannot focus just on data from one region. We need to be able to ensure that we validate this across many different populations. We're still working in this space, but so far what you see here is data from many different cohorts that we have looked at. And we pull the clinical labels that we haven't given these labels to the model, but we look at the scores that the model has given us and how they relate to clinical diagnosis. And what you see here effectively is patients that already have a diagnosis of Alzheimer's disease, the model primarily moves into the rapid progressive space. This is all done based on normative data in terms of we can now split, sort of bin these scores into stable versus progressive, slow versus rapid progressive. Patients that they have no dementia, the model primarily puts into the bin of stable. So this is kind of a first validation based on clinical labels, which the model has not seen in the training phase. Now, the most interesting thing for us is actually the bottom kind of part of this graph where it says pre-symptomatic. These are individuals that have volunteered for research but have no symptoms. They've undergone through the same tests that the patients have undergone. And what you see here is some of these patients, or most of them, fall under the stable space. Their scores are low. Potentially, they will remain into having healthy progression, no decline in terms of pathology. But some of them fall into the slowly progressive. Now, are these the people that we want to be following early through brain health checks? Are these the people that we want to be putting in clinical trials for developing targets that allow us to intervene early? And these are really hot kind of an important translational questions that we are hoping to ask. But of course, to be able to move these models to the clinic, they need to be trusted. And we keep working on building these models to be interpretable. As I mentioned, the first thing that we do is we ensure that all the markers, all the features, the diet of these models is clinically relevant. And we believe that this is actually really important for these models to then generalize to clinical data, and I'll show you a little bit of that. Then what we do is we open up the metric space, and we look at the weights. We look into how much each one of the features that we gave the model contributes to the model decision. And what you see here is the kind of hottest the color, the highest the contribution of each one of the features to the model prediction. Not surprisingly, amyloid is a quite good predictor. We know that it's a risk predictor rather than a, if you want, diagnostic measure. But you can see also that gray matter and APOE4 contribute. And the same thing, these are cognitive scores that contribute to the model. So that's one way to understand the interpretability. The other way is when we have the scores of the model, we ask how much they relate actually to clinical markers. So what you see here is the higher the score, the higher the decline in terms of cognitive decline. The higher the score, the higher the amyloid accumulation in the brain. The higher the score, the higher the atrophy in the brain in terms of reduced gray matter in the brain. And also the scores relate to APOE4 positivity. So these are clinical markers that we can validate the scores of the models against. And again, that increases the interpretability and the clinical utility. So the final thing that I want to show you is how we can now take these models and translate them to the clinic. And we can ask really questions of how we can change the clinical pathway. So if clinicians have the scores of these models for every new patient that comes to their clinic, and they have normative data, they can bin the patients, they can change the diagnostic pathway by looking at who is going to remain stable and who is going to progress. And this can be really a transdiagnostic approach. This is an approach that is looking on how we treat symptoms. So if somebody is stable, they can go home. If they are slowly progressive, potentially they need follow-ups. If they are rapidly progressive, they need immediate care to avoid, for example, other conditions that might accelerate hospitalization. Now, how do we know that this will work in the clinic? We took this model already trained as a trained engine, and we tested it against clinical data. We built it on research data, and now we validate it in real data from real patients that come from memory clinics. Now, this data they're much more broader in their demographic. They are much more missing and messy because it's everybody who went to their GP and got referred to a memory clinic. This is data from the Addenbrook's memory clinic. You see these are the scores of the patients. These are the clinical diagnoses that the patients were given, and you can see that when we apply this model to patients in the clinic, patients that already had a diagnosis of AD, the model says that they are already progressive and fast progressive. Patients that they have other cognitive disorders, functional attentional disorders, fall in the stable bin, which means they don't have dementia pathology. We did the same with data from Singapore. Singapore has a great digital database because they've been developing this for a long time. And you see again here very similar results. Our models are trained with US data. They predict about patients in Singapore and patients that already have the AD diagnosis. They are already in the rapidly progressive space. Patients with mild cognitive impairment are more kind of in the slow progressive, cognitive normal in the stable space. Now, the question that I'm always asked when I present this data is, okay, if you move this into clinical practice and a clinician has access to this tool and they're looking at these scores, how do they know that actually these are validated longitudinally? How do they know that the model makes a prediction today from that very first visit and assessment that the patient has about what will happen to them in the future, and that is valid? Is it ethically valid to give this, to use this for diagnosis in the clinic? So we looked at this data from Singapore. They had data for 10 years. What you see here is about 6 years in terms of that's where we have most, the highest bulk of the data. And what you see here is the model predicts at time 0. This is the very first assessment. And in fact, the model can predict only with clinical data. This is cognitive scales and an MRI scan. And if you take the prediction here of a clinician at the same time and you project what happens to these patients in the future, this will be what the standard of care is. Effectively, this is what we do now. A clinician makes the diagnosis at the first assessment of the patient, and then we can see what happens to them in the future. Some of them decline. Now, what we found when we applied the model is that actually 50% of the patients in this sample were stable. They remained stable. They didn't show any changes, any decline. This is 50% of people that, if we applied the standard of care in terms of the current diagnosis based on a clinician's diagnosis, they would have gone through for PET scans and lumbar punctures because they were diagnosed as having mild cognitive impairment on the trajectory for dementia. Now, 15% of them have a massively, drastically different trajectory. 15% of them are rapidly declining based on the model prediction, and 35% of them are slowly declining based on the model prediction. This is the longitudinal validation. We are very excited about this because you can see at 18 months' time already, these curves separate, which means 18 months' time, you will know whether you made the right predictions. 18 months' time, a clinical trial should actually show changes if the right people go in. And that's the final thing that I want to show you. we have trials ongoing, trials that have failed. We need to do something about the efficiency and the efficacy of these trials. And we can do this by changing the way we stratify patients. Currently, trials will recruit from this MCI space, the mild cognitive impairment space. But if we have more precise stratification, for example, with these models, people who are stable should not go into the trials. If they go into the trials and they get randomly kind of put into the drug group and the placebo group, simple statistics, this is not going to show any difference. Stable people could be screened out from the trials. And then who are the people that we put in, the slowly progressive or the rapidly progressive? It might depend on the target that we have in our hands. And just to show you quickly, we worked with a pharmaceutical partner. We looked at a trial that failed. It was a trial that targeted clearance of amyloid. When we tried to stratify the sample that they had based on APOE4, you see that it's a cloud. We cannot separate it. When we ask the model to stratify the sample, you see that it can separate nicely, slowly progressive versus rapidly progressive. Now, I can't show you the data, although I have now approval to present it in 2 weeks' time at the Clinical Trials AD conference in Madrid. But what I can show you is progressions from power calculations. If you put in only the slowly progressive to a trial that looks at reducing amyloid, you see that you need about 200 people in your placebo and 200 people in your target group to actually see a drug effect, while if you're putting in rapidly progressive, that will completely ruin your trial. So to finalize, I hope that I've given you some evidence about the potential really that we have with machine learning models when we make them robust and interpretable for these models to generalize into clinic and into clinical trials. I'd like to close by thanking a fantastic cross-disciplinary team of engineers, clinicians, computer scientists, mathematicians, neuroscientists, and everybody who gives us the funding to make progress in this work. Thank you.
Have we got any questions in the room? I had a quick question about data sets.
Yeah.
Are there any limitations to the data sets that you can use, and are there enough data sets out there to expand this?
Yeah, so when we started this work, it's about 10 to 12 years, actually the data sets were very, very limited. You might have noticed that I talked broadly about dementia, but actually all the slides talk about Alzheimer's disease, and that's because Alzheimer's disease is the most prevalent type of dementia, and that's where we now have more data. There's been a big push for people to open data. It's a huge plea to everybody, clinicians, pharmaceutical industry, to open data. We have secure data environments now that we can afford actually to safely work on data, and that can make a huge difference. So access to data can be a huge limit in terms of how robust and the validation of our models can be, but we also know that there are huge differences across populations. So data that we have worked with come from the US, come from the UK, come from Europe, come from Singapore. We now know that populations in Africa could have very different genetics, potentially different brain features. We need to be able to understand all of this, and we need to ensure that then the models we build take into account this variation, of course, in demographics, socioeconomic status. All of these make a huge difference. So it's a very important factor for building models that are validated and generalized, that then can make a difference in real life.
Thank you. Any questions in the room?
Yeah.
Aha, perfect.
So you mentioned that you use clinical features to train your ML model. So as you're going in progression, as a patient is going in progression, how do you make sure the ML model is being trained and learning through the other features, maybe due to environmental factors or anything, or age reflection, because you're also studying neurodegenerative diseases? How do you make sure?
Yeah, that's a good point. So there are some features that effectively we put into the models as regressors. So we want to make sure that differences in age, in education, socioeconomic status, sex. That's not what the models learn. And effectively, we will regress them out from the features that we put into the models. Now, we train these models with data at time zero in terms of the very first assessment that patients have, or the very first kind of baseline assessment that we have in a research cohort or in a clinical trial. And then we make predictions about the future. And when we make those predictions about the future, we look into trajectories. And therefore, we validate this prediction at time zero, the very first assessment, against longitudinal data. We are working now also with models that actually what they model is the exact trajectory, and Andrea showed an example of these event-based models. We've built these mixture state models that they take the whole trajectory of patients. These are actually quite powerful models because they contain more information about the progression, and we can turn them into being unsupervised. So this means they don't need any clinical diagnosis. We can apply them very early to data before people have any symptoms or any clinical diagnosis, and make predictions about their health trajectory in the future. So in these models, then we take into account actually the longitudinal data. The models learn from dependencies in time.
Thank you.
Yeah.
Okay, join me again.
I'm waiting to get the look on time. So if we can hold questions till over lunch, can we thank Zoe again for a brilliant talk?